Good afternoon, ladies and gentlemen. I just want to welcome you to this sixth session of Lifebulb Columbia education session for renal pancreas transplant patients. We will concentrate today on the follow-up of patients after transplantation. So the questions will be focused on that. You do have access to previous sessions, which are archived at the Lifebulb website under transplantlife.com. So you can reach back to the back sessions that were at the level of transplantation itself and how to prepare for it. This is going to focus on after the transplantation events. We're also grateful to Veloxis for partial support of this series of discussions, which will continue until October on a monthly basis. So first of all, I would like to introduce to you our moderators. I will start with the CEO of Lifebulb, who is also an MD and PhD, who was a juvenile diabetic, but is now a recipient of her father's kidney and of a pancreas for almost 12 years. So she knows something about this transplantation business firsthand. The other moderator is going to be Brian Runge, who is our chief coordinator for donors. Yes, raise your hand. That would be a good idea. I'm Mark Hardy. I'm a transplant surgeon, professor of surgery, and the founder of the Columbia Transplant Program. Our distinguished panel today consists of Dr. John Crew, who is assistant professor of medicine and actually a very important part of our transplantation program. He's one of our senior transplant physicians with many specialties, but particularly management of new immunosuppressive agents and also other things. Then we have Dr. Josh Weiner, who is assistant professor of surgery and a busy transplant surgeon, who is kind enough to just get out of the OR to join us. And he's also the director of intestinal transplantation in our program. And most important person here really is Shefali Patel, who is the chief coordinator for post-transplant patients, which really means that she does all the work and we get all the glory. So with that, we will start, and I will start with the first question, which I think I will direct to Shefali. How often do I have to visit the doctor in person or by video? And how often do I have to have blood tests done? What are the tests? And what do I need to do to get them?
So the first question is, how often do you come back to the transplant center? After your initial hospitalization, you usually are coming back at least twice a week. On rare occasions, sometimes you might need to see you 3 times a week, but on average, it's about twice a week. Those visits, usually the first week, they can take a couple hours. It will entail getting blood work done, and it's usually accompanied by a provider appointment, whether that's your surgeon, your transplant nephrologist, or the nurse practitioner. And so it's twice a week for the first month, and then it goes down to once a week for the following 4 weeks, and then every other week. And then we slowly taper the visits and the frequency. It goes down by like month 3 is when you start going to once a month blood work and follow-up appointments. And that kind of continues on until month 6. After that, the blood work is usually once a month until year 2. And then we kind of space out the provider appointments to every 2 to 3 months. So as time progresses, you don't see us as often, but for particularly the first 3 months is the busiest.
And any other comments, John? And you want to add to this, to anything?
No, other than that, it requires a lot of flexibility, kind of like Shefali implied, sometimes being seen 3 times a week. If there's an issue with the blood test, patients are frequently brought back. Part of the blood testing that we do is measuring the level of the immunosuppression. And so whenever we make adjustments in the medicine, we need to confirm that that dose is correct for the patient. And so patients are frequently called back extra time to get extra lab work done or extra visits done, just to help adjust the medicine. And most of those extra visits are in the first 3 months. Beyond 3 months, when patients are on kind of stable doses of immunosuppression at levels that they could tolerate without too many side effects, life becomes a lot easier.
And
I had a question for that. Are the drugs that you are on, that you prescribe upon transplant, they, as you mentioned, that includes the immune suppression, but there are also some other drugs. What are those?
So sure. So it depends, varies a little bit by the center. There are a couple common infections that we see in transplant patients that are just related to being on these new medications. There's one infection called CMV, cytomegalovirus. It causes a syndrome that's similar to feeling like you have mononucleosis that a lot of us had as kids. And it hangs, it's a virus we're exposed to when we're children, and it hangs out in your body your entire life. So then when you take transplant drugs, sometimes it can become active. And so that's a medicine called Valcyte or valganciclovir. We give another medicine to prevent lung infections because of the immunosuppression. You are at risk for having bacterial pneumonias, things like that. And so most of our patients get an additional medication for the first year to help prevent pneumonias. And then the third medicine that patients get is a liquid to help prevent fungal infections. Again, because the intensity of the immunosuppression, there's a chance of getting a fungus infection, sores in your mouth, sores in your throat that can make it difficult to eat, make it difficult to drink. Obviously, if you can't eat and you can't drink and you have a fresh kidney, you get dehydrated, the kidney's not going to make enough urine or get enough flow. Now, we're able to take those medicines away over time because the intensity of the immunosuppression goes down. As the intensity of the immunosuppression goes down, people don't need quite as much to prevent themselves. So it's definitely true that at the beginning of the surgery, people are on a lot of new medications, but over time, those medicines become simpler and simpler, fewer and fewer. So it's usually by 6 months or a year, patients are on fewer medicines and lower doses of medicines than a typical dialysis patient, actually.
So a question just for quality of life as a patient, when you're on this more heavy immune suppression and you're on more drugs, are there any additional requirements that you're asking the patient to follow beyond coming to the hospital? For example, are they able to go on a flight? Can they go back to work? Can they see young children or have pets? Are there other accommodations that you recommend for fresh kidney patients to take?
Sure. So the restrictions that we have on patients, it really varies by time after transplant, kind of like as I implied with the other medicines that people take, the prophylactic medicines. Certainly for the first month, when you're on the highest doses of the medicine, we don't want you riding the subway, riding the bus where people sneezing on you, coughing on you with COVID, seeing little babies who could be sick. As people go on after the transplant, they get more and more freedom. And so after the first month, 2 months, we allow them to go back to restaurants, eat at friends' places. Our patients even take the subway, and eventually, I have patients who work in daycare. I have patients who are garbage pickup people. And so eventually the level of immunosuppression gets to a point where where they can go on and have a open life, be with their friends, travel, go back to work and do things. And that really happens, that sort of transition happens over the first 6 months. The strange thing is actually, so we worry about all these pills and immunosuppression with transplant patients and the risk that it causes for infection. It turns out that actually kidney disease on its own is very immunosuppressive. And so dialysis patients, just by virtue of having kidney failure, They're actually very immunosuppressed too, and actually more frequently, dialysis patients are more often admitted to the hospital for infection than transplant patients. Part of that is related to the access procedures that we need to get at the blood to do dialysis, or the peritoneal dialysis can get infected. But actually, a lot of it is pneumonias and other infections unrelated to dialysis that are just related to the immunosuppressive burden of having kidney failure. And so with the transplant, we ask our patients to use common sense, to be very cautious, particularly early after transplant. But actually, our expectation is that they will go back to work, that they will travel, and that as long as they wash their hands frequently. With COVID, we prefer patients wear masks, obviously, when they're riding planes, riding buses, things like that. But the expectation is that long term, there will be few restrictions at all other than just common sense.
And can the patients get their blood test done elsewhere? Do they always have to come to the unit to get it done? Shefali?
So for the first 3 months in particular, because there's so much variation and the complications that we could see early on, we tend to have all the blood work done at the transplant center for the first 3 months. After that, we do kind of help set up blood work where you can go to a Quest or a LabCorp to, a local hospital and not make your trip back into our transplant center. So there's definitely depends on what we're looking for. Routine blood work later on, yes, get your blood work done by your, closer to your house. But the first 3 months, we try to keep it at the transplant center.
Our patients really have to. Our patients have to understand that we need to have standards from the laboratory. In other words, the baseline has to be from the laboratory, because the baselines themselves vary from laboratory to laboratory a little bit, but for our purposes, that may be significant.
So Shefali, a question on that. As we speak to a number of transplant patients who are kidney as well as heart and others, and heart patients are, really required to stay for a longer period close to the hospital where they had the heart transplant. And you're saying that the kidney transplant patients really should go back, and I totally understand that, and I appreciate that. Are there ways to accommodate for kidney patients who do not live close by? How do you attend to that? Are there programs for them to get housing or transportation? Is that something that you are looking into as well?
I can't speak of specific programs out there. Maybe Dr. Crew, Dr. Weiner might have some suggestions, but I don't know about the specifics of programs locally to our center specifically. I know that many patients, we talk about this before the transplant and try to make sure that we have arrangements and things made prior to, just because it gets so complicated and a lot of patients are overwhelmed in the first 3 months. So we try to develop a plan before we can go into the transplant. Not sure, do you guys know if there's any specific support?
Well, we sometimes, I may try to answer this, and I hope that John and Josh will pitch in. But in fact, if the patient is doing very well, after about 6 weeks or 2 months or so, and if they happen to live in Syracuse, which is we have patients like that, we try to make arrangements for them to be followed by the transplant nephrologist in the city that they are, where they live. And then we get the laboratory data directly from either the hospital or from Quest. And in fact, we do have programs that our coordinators arrange so that LabCorp and Quest actually feed into our computer so that we get the online laboratory data. It's not very desirable. We are concerned a little bit about it, and we certainly would like the patients to get back to us if there are any problems. Otherwise, we do loosen up the reins a little bit in order to make life possible for them and avoid having to stay in New York and at a higher cost and so forth. But most of the time, as Shefali said, we really ask them to, we demand that they have some arrangements for at least a month to stay around. Because they have the sutures, they have the wound, they have all sorts of other problems that I hope that we will discuss in a moment. Now, in terms of medications, they also have the other medication, don't they, John? They have the blood pressure pills and all that sort of thing. Do I have to take all my medications that I was taking on dialysis? I have to take that and more?
Well, the medicines are going to change. For example, blood pressure medication. Blood pressure is usually easier to control with a transplant that's functioning well compared to blood pressure on dialysis. So the average dialysis patient takes 3 blood pressure medications. After a transplant, they usually will go down to 1, maybe 2. Dialysis patients take a lot of medicine for phosphorus. That actually goes away completely. In fact, some of our patients actually have to take extra phosphorus. Things that taste good, you know, ice cream, cheese. But for example, we're not going to fix cholesterol. If someone has had heart disease in the past and has high cholesterol, they're going to have to continue their cholesterol medications. And absent getting a pancreas transplant, we usually don't fix diabetes either, for example. So those patients end up staying on insulin or staying on oral medications to help improve their And so some of the medicines go away, like the phosphate binders. The medicines for potassium frequently go away. Blood pressure medicines usually are less. And some of the other things, particularly heart medications, this heart disease and kidney disease dialysis are so commonly go together. Many of the heart medicines actually continue on after the transplant.
And who will pay for all this?
Excellent question.
Josh, suggestion?
Well, one of the nice things about transplant is that it was recognized by the federal government to be actually not just a good thing from a health perspective, but the thing that matters to the federal government is a cost-saving enterprise from a health perspective, because the cost of a transplant, as high as it is actually less than the cost of years and years of dialysis, both the dialysis itself and all of the health problems that go along with it. So you can make fun of Al Gore all you want for claiming to have invented things in the past, but Al Gore was actually one of the prime movers and shakers behind the 1984 act from Congress that really contributed to coverage of the costs associated with kidney transplant specifically. So most of the costs that we're talking about are covered by insurance or by Medicare and Medicaid because of that.
They covered the immunosuppressive drugs, and in fact, it's interesting you mentioned Al Gore, because Al Gore actually was very instrumental in getting the government to pay for the immunosuppressive drugs for 1 year. Then it was extended to 3 years. And now I think isn't it permanent already for immunosuppression?
There was actually one of the things that the Trump administration did.
Yes.
Not talking about politics here, but was really good things for kidney disease. And I don't know if Josh, you seem to know, there was an update, I believe, in was it 2019 on kidney?
Yes.
Part of that is again leaving politics aside, because people have various opinions about Health and Human Services Secretary at the time, Alex Azar, but he actually had, I think, a brother who had a kidney transplant, and he was very sensitive to the kidney transplant community and was very responsive to ASTS in particular, the American Society of Transplant Surgeons, and worked with that community very closely to do some good things for transplant, as you mentioned, in terms of coverage.
Our very educated audience actually is correcting us that in 2023 it's going to be lifelong. So we have 1 more year. Thank you, Sam.
That's why I asked the question, because I wasn't sure that it was already passed through. I do know about when it went to 3 years, because I actually was the president of ASTS at the time, and I was on a program for 1 hour with Gore, trying to convince the world that this is the thing to do. Anyway, aside from this, what do we do about all the other medications? Who pays for for the blood pressure pills and the Valsite, which is expensive? Do we have methods of doing it, or this is just goes back to their original plans? Those things any one of you can answer, because I don't know the answer.
So it depends on, it gets very complicated depending on whether you were working and had private insurance before the transplant or not. Medicare Part D covers most of those other medications if you qualify for Medicare. Many people need a supplemental plan. If you have private insurance, then the private insurance plans will cover that too. Specifically with the immunosuppression, the immunosuppressive manufacturers are very helpful for us for when there's gaps in insurance coverage, because like you hinted at, medicine's pretty expensive. And so they have patient assistance programs where our patients can apply if they meet certain financial qualifications. They can apply to get free medications for a year for particularly versions. Fluctuate actually has been very good with us. Versions of mycophenolate as well, and valganciclovir, another virus medicine called Termavir. All those companies have been very helpful for our patients when the insurance coverage is inadequate or the copays become too burdensome.
So, but Shefali, this was kind of what you were hinting at, that the process prior to transplant, and we did address this in prior seminars, where we talked about evaluation of the person's financial status as well as their insurance coverage, and how, because for a transplant to be successful, we don't just need providers, we also need ability for the patient to follow and to be adherent. We did have a question here on the drugs that I just wanted to bring up. A person is asking, are there programs where steroids are not used? And I know for a fact that Columbia has a program where steroids are not used post-transplant, but maybe Dr.
Maybe Josh can comment, and since he has worked in other units.
Highly variable.
So it's variable to the point where, what would you guess, what percentage of units in the country do not start out with steroids? I thought it was about 60 to 70%.
Any answer I would give would be highly anecdotal, and so I'll defer to somebody who may know better than I do. My impression is that more did use steroids.
So, the immunosuppression is reported to the government in the SRTR, and so in this year's report, it was 40% of patients. So that's not necessarily centers, because each center is doing a different amount. Some are doing 200, some are only doing 50. But 40% of patients are sent home from the hospital without steroids.
Without.
Correct.
Okay, so it's still a majority who get steroids.
Yeah.
Well, in our unit, actually, it's a tiny minority that actually comes in with steroids beforehand for one of their diseases. Those patients usually are continued on the low dose of steroids that they had before. For illness, not because of immunosuppression.
So speaking now from the patient perspective, and I need to just bring this up, you've been talking about a lot of drugs, and we do want to talk about some of the surgical consequences and follow-ups as well, meaning the incision and some of the complications that can happen, and the reason why you come in and look at that, even though the surgical incision for a kidney transplant is minimal, but still. On the drug perspective, having that many drugs that could potentially interact with one another and could cause some nausea and other side effects, what do you do, if anything, to help the patients with the diet accommodating for these drugs? Any advice? Do you have nutritionists involved? How is that handled? Maybe Shefali can start.
Sure. And so during the visits, right, the early on visits, we take it day by day, week by week. It kind of depends on the patient. We cater towards the patient and what side effects are tolerable and what side effects just are not tolerable, and we have to switch drugs or come up with other ways. We do have a transplant nutritionist that often gets involved. We have transplant pharmacists that help out as well. And over the first couple of months, we come up with a regimen that's the least amount of side effects, and come up with ways that we can, minimize the side effects, but still gain what the transplant drugs need to do.
Good, well, thank you.
And Josh, can you, as long as we raise the issue of complications, could you just sort of give us a brief run on what kind of problems the patients can come back with after the transplant, other than rejection, obviously?
Sure. The good news is absolutely none. No, I'm just kidding. It almost
only when you operate.
It almost always goes well, but of course, transplant is a very complex field that is particularly prone to complications. I'll mention, by the way, first of all, happy National Donate Life Month. April is Donate Life Month, so I do want to put in a plug that if you or anybody you know are not signed up to be a donor, or if you know people who are considering being living donors, this is a great time to reach out to them and get more information. And I won't take up more time talking about that here other than to plant that seed. I'll also just quickly answer two things that popped up in the comments just so they don't get lost. One question about pets. No, you don't need to say goodbye to all of your pets if you get a transplant, but at the beginning, while you're most immunosuppressed, you might want to get somebody else to pick up the cat litter.
And we don't particularly like birds. We do not like birds for our patients. So there are people who have parakeets and that sort of thing. Those are a problem, a serious problem, because they do have diseases that we don't like.
And one other question about steroids being prescribed for other types of solid organ transplants. Yes, kidney is the rare one that you can try to get away from steroids. I think every other type does have lifelong steroids, or at least.
What about management of the wound or the drains or?
Yes, so let's turn to the surgical complications.
And pain and some little blood every once in a while.
Yeah, so the good news is that if you're asking this question, it means that you've gotten a transplant, or that if you're facing those problems, that you've gotten a transplant. So congratulations already. And as I mentioned, transplant is because of the surgery itself, because of how sick people tend to be going into it, and because of the medications you get afterwards, it's particularly prone to complications. So let's talk about some of them. The most common types have to do with blood vessels. And the one that is most common sounds the scariest, but is not. And that's what happens when the blood vessels bleed after transplant. It's a fairly common occurrence after kidney transplant, especially because, as you might know, if you're on dialysis, you tend to be particularly prone to bleeding. Your platelets, which cause clotting, don't work as well. We have bleeding in about 15% of our kidney transplant patients after the transplant. Sometimes we even have to go back to the operating room, and almost never is it a big deal. It's something we can fix.
But going back to the OR, you're talking about a minute number of patients.
Minute, I wouldn't necessarily even say minute, because it's really in the 5 to 15% range, but it's a minute setback. It means you're in the hospital a day or two longer, and usually nothing much more than that. Almost never.
But Josh, would this happen in the time that the patient is in the hospital?
Almost always.
3 to 5 days or so.
Always.
Yeah. It doesn't often, in 10% of the cases, in 1 in 10, doesn't happen when patients come back within the first 3 months, right?
It's almost always at the beginning. There are cases where it's delayed, particularly if people are on blood thinners, which they are for some reasons, especially if we're doing a transplant for somebody with an artificial heart valve, or for somebody with clotting disorders like APLS. It's Antiphospholipid Syndrome, which was one I did a few months ago with a patient who had to be on therapeutic Coumadin that we couldn't stop. And we did that transplant knowing that we were most likely going to encounter bleeding afterwards. And we did, and we dealt with it, but sometimes that happens. But the point is that bleeding can be an annoyance, but almost never is it a big deal. The thing we worry about much more is clotting. And if clotting happens in either the artery or the vein, unless it's dealt with immediately, recognized and dealt with immediately, and sometimes even if it is, it can be a catastrophic problem. The good news about that is that it's very rare. It almost never happens. But if it does,
you do testing frequently in the first few days, don't you?
That's correct. And if there's anything that we see that concerns us immediately, such as a sudden fall in the urine output or an increase in the creatinine, then we look into it right away and try to troubleshoot it in case there is something we need to address. Besides the blood vessels, there's, depending on which center you go to, this happens more at the more aggressive centers, there's something called delayed graft function, which at our center happens in about 50% of our patients. And that's because kidneys that
Just 50% of those who get kidneys from deceased donors.
Correct. Not as much the living donors.
Living donors, it's relatively rare.
Correct. This is when the kidney, to put it very simply, gets insulted by the way it gets treated in the rough process where it gets taken out of one donor and put in storage in between, and then has to be not getting great blood flow while it's waiting, and then also waiting on ice, and then also while it's warming up while we're sewing it in. And it creates a process called acute tubular necrosis in the kidney, which almost always gets better. And that manifests in the recipient as something called DGF, delayed graft function, as we're waiting for that ATN to get better. And just like the ATN almost always gets better, the DGF almost always gets better. Almost never does it not get better. If it doesn't get better, that's something different. That's something called PNF, primary non-function. We very, very rarely see that happen. When I say very rarely,
Doctor, so that is not rejection, but that's just the kidney not taking, or how do you define it medically?
Not taking is a perfectly good way to put it. Sometimes we don't even know the reason.
Yeah.
Sometimes it's because it just had too much ischemia time, meaning either a time on ice or time getting warm where it wasn't getting good blood flow. And that itself is colored by the quality of the kidney to begin with. A very, very good quality kidney can take more of a hit from that than a kidney that was already marginal. And so there's a lot of factors that go into this, some of which we can point our fingers to, and sometimes some that we can't. Sometimes it just happens, but it's very rare. But when I say very rare, I mean 1% of the time or less.
So a hypothetical, if the kidney doesn't take in one person, could it potentially take in another person who's also available for a transplant in that hospital?
You mean that same kidney? No, we don't take it out and put it into somebody else at that point.
I had to ask.
But yeah. in the very rare case where this happens, the consolation prize is that besides having gone through the surgery, the patient doesn't lose their time on the waiting list. They get back all of the time that they've been waiting.
So they'll end up on top.
Sorry?
So they'll end up on top again.
Yes. So
because they must have been on top to get it in the first place.
Yeah.
So you don't lose any chances of getting a transplant because you've had one that failed, if it failed in that way. Yeah. Rejection, I'm not really going to talk about because it's not a surgical complication. I'm sure we'll talk more about that later. But I was asked to sort of cover the surgical complications. Other things to think about are about 5% of the time, there's a disruption of the tubes that carry fluid from around your cells back from your legs to the rest of your body. Those are your lymphatic channels. And if those get disrupted in a way that leaks around the kidney, fluid can build up in a way that accumulates and can press on the kidney. If that happens, it's called a lymphocele. And we either drain it and it goes away eventually, or if it doesn't, we can perform a very simple type of surgery to fix it, where we just put a small scope into the abdomen and create an opening in the peritoneum, which is the sac around your intestines, in a way that allows that fluid to drain back into your abdomen where it's absorbed. When I say back into your abdomen, I say it like that because most of the time the way your kidney is placed is it's where you think of as your abdomen, but it's actually placed outside the abdomen. It's outside the peritoneum where the blood vessels are, and not inside the sac where the bowels are. And that's an important difference. You can think of it as more being in your leg.
Yeah.
Other things, about 5% of the time, the connection between the ureter that carries the urine from the kidney to the bladder can either be narrowed or it can leak. In that case, that's something that would need to be fixed. Early on, we would fix it with a surgery to redo that connection. If it's later, sometimes it requires a surgery to bring up your body's own ureter and connect it to the kidney itself.
So the transplanted kidney comes with a ureter.
Correct.
I just want to make the point. While if it doesn't work with the transplanted ureter, you use the existing ureter for the native kidneys and bypass or use that that transport and disconnect it from the native kidneys.
Yeah, that's right.
Excellent.
And every once in a while, the ureter can leak also.
Yes. So and that was that's part of that 5% of either leaking or narrowing. Getting into even less common things, sometimes the way we place our retractors can pull on one of the nerves that goes to the leg in a way that can make the leg numb for a period of time, sometimes a couple of months. And that will almost always get better. It just takes some time. And that's a very rare occurrence. That's less than 3% of the time. And then, of course, getting into the most rare things, sometimes with the kidney transplant, as with any time that you go under anesthesia at all, even if there's no surgery involved, there can be a risk of death. We really don't see that very commonly, but it's worth mentioning that is a known complication.
Yeah, we do need to take some questions because we have a lot coming in here from the audience, and I don't want to be disrespectful. One question, and I think it's just a clarification for you, Dr. Weiner, a sleeping kidney. What is the definition of a sleeping? I think you've explained it, but maybe just define it as your medical terminology.
Sure, it just means that kidney doesn't work well for a period of time. It's getting perfectly good blood flow. Everything's hooked up. There's no technical problems. It just needs to get the oxygen and the nutrients from the blood for a few days or sometimes even for a few weeks before it really starts functioning well.
It's the same thing that Dr. Weiner mentioned is this ATN,
right?
This delayed graft function. That's what we call sleepy kidney because the patients like that term more than DGF or ATN.
Yeah, and as you described, that is one of the good ones to have because in most cases it wakes up.
Almost always wakes up.
Yeah,
and it really is a major. It's a problem in deceased donor kidneys. It's rarely seen in living donors. It may be to some extent for a few days, but no longer. If it starts.
right. I think a question now for Dr. Crew. There's a person here who's asking, is it common for creatinine levels to fluctuate post-transplant? When do you reach a stable creatinine level optimally?
Ever. Yeah, so unfortunately, it's very common. All the pills and immunosuppression we mentioned, they're all designed for the immune system. They're not necessarily specifically designed to be happy for kidneys. And so one of them in particular, Tacrolimus, can cause the creatinine to fluctuate a lot. As a sort of and particularly at the beginning of the transplant, when the doses of medicine are the highest and the kidney hasn't completely recovered. In fact, it takes about 6 months to reach the lowest creatinine. So for some people, the kidney grows for another 12 months, even 2 years. There's even one study where they looked at people who had received some female kidneys. Female kidneys just tend to be a little bit smaller because the body size is a little bit smaller, but they continue to grow for 5 years. And so the creatinine fluctuates a lot at the very, very beginning, depending on the level of the medicines, how hydrated you are, and how the kidney is healed. It becomes much, much less common after the first 6 months.
Again, having gone through this, I can tell you that's one of the biggest stress levels for a patient is to get your creatinine level and to try to interpret it yourself and say, okay, what does this mean for me right now? And the difference in and I think for you seeing so many, maybe there's some comforting words you could say to the patient that there's only when there may be only a few occasions when you really are alarmed. And I think after that, we want to get into rejection.
Sure. And so, as a segue into rejection, there are so many different things that cause the creatinine to fluctuate. 100% of people will have a creatinine fluctuate. Fewer than 10% of people will have rejection. And so the majority of the time when the creatinine fluctuates, it has something related to due to hydration, issues, interaction with the medications. Sometimes, like Dr. Weiner mentioned, plumbing problems that can be fixed in different ways. Rejection actually is one of the fewer causes of the change in creatinine, even though it's what is on everyone's mind.
Speaking to rejection, there's a person here who's quite advanced in their question. They said, are there some genetic markers, or are there some markers that can be studied to analyze early stage rejection, or is it only kidney biopsy that is being used?
That's an excellent question. We're still working on some of those tests. There are some. So the good thing, for those who haven't experienced a kidney biopsy, we bring people into our infusion suite. We use an ultrasound machine to localize where the kidney is. We give anesthetic from the skin down to the kidney, and we take 2 pieces to look at under the microscope. It is, it's usually, it's not painful, but it is a procedure, and there's always a chance of bleeding. It's costly, unfortunately, because of the procedure and the processing, but it does give us a lot of useful information.
And it can be done in the hospital. It is done right at the bedside.
Correct. It's done at the bedside. We do it as outpatients all the time. Now, but it is worthwhile trying to find a test that will replace that. And the tests that we have now that can replace it. So one is they look for DNA. They look for, say, the kidney is being damaged. Some of its DNA might actually be released into the blood, and you can measure that. And it correlates with rejection somewhere between 8 and 9% of the time. Sorry, 8 or 9 times out of 10. The question that we struggle with is that good enough? Do you want a 20% chance that you're missing rejection? There's some other hormones, these things called cytokines. They're the signals that the immune system uses to talk to each other that they're testing, that again are around the sort of 80-90% mark, where they're pretty good, but not quite good enough. And I'm actually supposed to be giving a lecture. I spent my day writing a lecture on this today about what the alternatives are going to be for to determine rejection. And so we're making a lot of progress. There's nothing yet that will 100% replace the biopsy, because in addition to the telling rejection yes, rejection no, different grades of rejection, different severities of rejection are treated differently. And so these blood tests are probably going to be markers for, yes, this kidney is at risk. Let's do a biopsy so we know early that what treatment plan we can go for.
So it's like Cologuard.
Yeah, kind of. Yeah, exactly. You detect a DNA change, and you're like, oh, that person has a polyp. We'll go take the polyp out or make sure they don't have cancer. Sure.
So you still have to do colonoscopy and go through fasting.
If you have a positive test. Yeah.
Yeah. Okay. I have some more questions, unless you want to go to the next topic, Dr. Hardy. But there's a question here on, if you get another transplant and you've already had a second or third transplant, and maybe this is for Shefali, are there any pieces of advice that you can that you emphasize as the coordinator to take better care of this kidney and be more successful with this kidney if you've had rejection or lost 1 or 2 kidneys?
To really address compliance issue.
If compliance played a part of it, but many times it's even, our patients are great. They're responsible, right? They know what they went through. It's not easy. It's been a long road to get to transplant, and often take great care of their kidney. And unfortunately, many people need second and third transplants. And so they often have the tools, to live a healthy life and prepare. We try to advocate for living donors and prepare if they need to, so that if they need a second and third transplant, they get it before seeing dialysis. So getting relisted is important. So just getting I don't think there would be anything different.
So it's a bad idea to really live in denial and say, my kidney is going to be okay. You really have to accept the fact that it may be deteriorating and getting prepared for a living donor, or hopefully.
Especially if you're on Tacrolimus.
So, well, we may as well go on to this. So why don't Josh and John, both of you can comment on the problems with the drugs, starting with Tacrolimus, Rapamycin,
And there's a question here from the audience saying, what's the advantage of belatacept?
Well, I'm not impartial to that. So John, start.
Sure. Okay. So
Tacrolimus.
And what are the negatives? What the comparison?
Right. So I mentioned before that the tacrolimus is designed for the immune system and not for kidneys. And so the side effects, one of the side effects of tacrolimus is it causes the blood vessels in the kidney to squeeze down tighter. And if the blood vessels are squeezing down, the kidney's not receiving as much blood. Kidney's not receiving as much blood. Creatinine starts fluctuating. Over long periods of time, that can cause scarring inside of the kidney. Now, up until recently, we haven't had any very good alternatives to it. An alternative that was the alternatives that we tried, they were gentler on the kidney, didn't have that same toxicity, but you were treating off higher rates of rejection, and the rejections were causing more damage than the drugs were. And so until recently, I say with belatacept. So belatacept is an IV medication. It's an infusion once a month. It works differently than the other medicines that we have. Doesn't have this nephrotoxicity or kidney toxicity. Doesn't make the creatinine fluctuate as much. It has a couple limiting factors. You have to have been exposed to mono in the past for reasons related to some cancers, particularly something called lymphoma. It is for people who are young and want to travel. It can be frustrating to use because you could say, I'm going to go to Puerto Rico next week because it's my friend's birthday. Oh, I'm not going anywhere. I have belatacept due and I can't miss my infusion. And it's something that's very difficult to get outside of the country. So you have to make plans on that. In terms of direct head-to-head comparisons, tacrolimus, when you actually do randomized trials of tacro versus tacrolimus, so far the outcomes are very, very similar. There's a slightly higher rejection rate with belatacept compared to tacro. There are slightly better kidney function with belatacept compared to tacro. Patient outcomes, patient survival are the same so far. I think probably an important thing to understand is that everyone responds differently to these medicines, and some kidneys are very, very sensitive to tacro through some genetic differences. Every kidney genetically is different. Some kidneys are very, very sensitive to it. That sensitive kidney is going to do better on bela than on tacro. There are other people whose immune systems, for whatever reason, are just they work differently. They're too potent, where belatacept is just not going to be good enough for them, and they're going to have repeated rejections. We don't have a way of knowing yet a priori before the transplant who's going to be best with what. And so in the first 3 months, one of the reasons for these frequent visits is adjusting the medications and finding the right combination that works for the patient and works for that kidney.
And also, I think, mentioning that there's a long-acting tacrolimus that does have less toxicity and less side effects. So that's I guess is a little baby step away, at least from that.
Yeah, and so certainly we use a lot of Envarsus, and our patients love the fact that it's once a day. And so it does make some difference, certainly in terms of quality of life. Swallowing pills, the dosing is definitely much more convenient. But there's some kidneys that even with Envarsus still can't tolerate.
Yeah,
but there are, of course, other patients with other organs who get tacrolimus and then lose their kidney function, and that's a very significant number.
Correct.
So
after 10 years, it's about 10% of liver and about 12% of heart transplants will be on dialysis because of the immunosuppression.
Because of tacrolimus. So this is the argument for belatacept is, as far as I know, actually the creatinine and the glomerular filtration is better after 7-10 years compared to
cyclosporin. Yes, compared to
cyclosporin, and in some small studies compared to program. Now, what about other drugs like rapamycin? This is not used very commonly, but because it has some problems with wound healing, perhaps, but it may be another escape mechanism. Could you comment, Josh, on the alternatives that people have and that the physicians have in changing medications? If there are problems with one, you change to another. We now have more medications to use.
Sure. And this is a very complex and nuanced discussion. So I'm only going to comment on it kind of superficially and briefly, but and also because a lot of the options have been mentioned already. For example, changing to Elatacept, which is one of the newer options that we're doing. There's also things like one of the medications that you'll take after transplant most commonly is called Cellcept. And if that's not well tolerated, we can change that to other things. We can use options such as azathioprine, otherwise known as Imiram, or we can leave it out, and there's other options. Rapamycin is another alternative that's been mentioned already. And then there's other forms of rapamycin coming down the pipeline. So it's really highly variable. It's debatable. It's highly center dependent, and it's very nuanced. And it depends what your other medications are, because everything is done kind of in balance. So the main point of this is really that there are other options, but it's really hard to touch on the detailed pluses and minuses of each one in isolation beyond that for a type of talk like this.
Yep.
So we're coming toward the end of our discussions. So can you just comment on the real problems that we do occasionally encounter? And I open it to all of you, and that is one of the serious side effects that we worry about are viral infections and fungal infections that patients occasionally get. We live now in the COVID era, which makes everything a little more complicated. And I noticed someone asked a question about vaccinations. I think that you must really, my feeling is that you must get the COVID vaccine before you get a transplant. The other vaccines are the ones that have been, that are suggested to you as part of your workup, which really includes hepatitis B, mumps, not mumps, I'm sorry, whooping cough, and also the influenza vaccine on an annual basis. Now, do we recommend the, I'm actually not sure whether we recommend the vaccine for, what is it, shingles.
The new Shingrix vaccine is just recently approved for kidney transplants, and so it's recommended but not required.
Right, the others are actually required. So hepatitis B, influenza,
Yep.
and whooping cough are not whooping. Yes, whooping cough.
Oh, you're right, pertussis.
This time I was right. Right, so those are required by us, and COVID is required by us as well.
So we I think we have covered a lot, and this we could continue because there are questions coming in, and I think you all are such fantastic contributors. I want to just one final question, and to bring Brian into this, because we haven't heard from Brian, and you know, I just want to. We have talked so much about how the recipient is after the surgery, and what the recipient is doing. Just one comment on our wonderful donors. You know, is there anything for how often they come back, and what is their protocol? Just briefly, and then I think we do need to
brief.
close.
It's so hard because donors are so wonderful, you know. But donors do extremely well post donation. They're in the hospital 1 or 2 days, back here to see the surgeon once, and then usually that's how well they do. Every once in a while we get I'll get a call about similar complaints of fatigue afterwards. That's very common after donation, but it eventually goes away. And some people, it might take a week, some people might take months. Everybody's different. The pain they experience afterwards is more geared towards it's not necessarily the surgical pain from actually cutting the kidney out, taking it out, and the wounds. It's actually abdominal discomfort from the gas they inject during the surgery, and constipation from the pain medications and anesthesia. Those are the two, the pain and the fatigue are the two biggest things that I get calls for after donation. And these people go on to live their entire life with one kidney and don't have an issue, but we're always there for our donors. We follow them up to 2 years because that's the regulations. After 2 years, there's no need for any follow-up. They go see their primary. But that being said, 40 years down the line, if a donor's having an issue, we're there for them. They can pick up the phone and call this number. Maybe I'm there, maybe it's a new coordinator, but there's always somebody here that can then help them through what their doctor may think is kidney problems or anything. And I rarely get those kinds of calls. People may not even know they have one kidney until they get worked up, and then we find out they have one, and they might be in their 50s, so they've lived quite a long life with one kidney. So taking it out while they're young is very, very safe, or else we wouldn't be doing it, or any transplant center around the country or world. We have to do it right for the donor because it's an elective surgery for them.
Shefali, tell us quickly what I'm not allowed to eat.
What are you not allowed to eat? Pomegranate.
I'll talk with great. Okay, pomegranate and grapefruit.
Grapefruit.
What else?
Yeah. And then it
How
kind of
about sushi? Can I eat sushi? Can I eat
No.
steak tartare?
Sushi,
Anything
not so
raw?
Let her speak.
We try to avoid those things. So raw meat, sushi, and things like that. We kind of no pomegranate or grapefruit because there are some drug interactions with the Tacrolimus. The other big thing early on after the transplant is Potassium Foods. And so we'll let you know if potassium becomes an issue. It's one of the tests that we monitor with all your blood work. But other than that, there's not many restrictions.
What about salad bars?
Salad
John,
bars,
do you recommend?
Salad bars are tough because it depends on where you're going.
Yeah.
I wouldn't recommend eating at a food truck, but if you're at a nice restaurant, this all comes down to how much bacterial load is in the food. So if it's not cooked, not cooked beef, not cooked fish, you could get in trouble. I got to tell you, like, my patients eat sushi even though I ask them not to.
Yes.
They usually don't get sick.
and they
But
do.
shellfish, man, clams, oysters, literally every single time people come in with diarrhea, nausea, vomiting, and so be careful.
Yeah.
And Josh, can I go skiing? And can I dive? I like to dive.
So divide it into two very quick parts. The first part is immediately after your transplant. The second part is later after your transplant.
Later. Let's assume we don't do it later.
We're talking about post-transplant. Okay, let's do it.
But well, the quick answer immediately after your transplant is no heavy lifting or strenuous exercise for the first 6 weeks. Done. After that, yeah, I wouldn't do anything that risks banging the area where your kidney is, but be smart. But beyond that, you can live pretty much a normal, active life.
But you would be careful about diving when you can do belly whops.
If you did a belly flop so hard that it damaged your kidney, then I guess I would just have to be impressed at that point. So don't do that. But
okay.
Yeah.
Anything that you wouldn't let them do. How about playing lacrosse?
I would tell people to be smart. If you think that you're at risk of getting hit very hard in the area where your kidney is, then don't. But that's not usually an area where you get hit particularly hard. So, but everything in moderation. Don't do things that are obvious injuries to that site or where you think you're going to be at risk. But these are things where you are all smart people who can use your judgment. There's no absolute no's at that point, at least that I would say. It sounds, Dr. Hardy, like you may be more strict than I am.
Only in some things. Lacrosse, I wouldn't let them play. Anyway, so I just want to thank the panel for being very well informed and very well spoken and really
Quick on your
very
feet.
informative is the word I'm looking for.
Yeah.
So very informative to our audience. And I want to reassure the audience that our team is always there if you want to ask more questions. And we will be back. We will be back on 5/18 with another session, which will really cover other matters like the risks of being pregnant with a transplant and what are insurance coverage. It will be broad topics of every sort, including insurances, pregnancies, and how to connect with other patients to talk on lifeboat with them or any other type of connections. So I welcome you and prepare yourself for 5/18, the same time at to answer where we will answer some new questions that are of concern to patients after transplantation.
Dr. Hardy,
So thank you very much all.
May I interfere with your beautiful send-off just for 1 second, just because enough people asked the question about swimming that I don't want to disappoint the 3 million Elvis fans. So the very brief answer is yes. After your wound heals, which is the first 2 to 4 weeks, you can take a shower from the beginning. After that, after about 4 weeks, you can go underwater, like a bath or a swimming pool. And then beyond that, you don't have to worry about swimming as long as you're not doing it in sewage.
Great. Well, I want to thank everyone and thank the audience. Thanks for your great questions. And again, we will be back. And as you know, this can be found on transplantlife.com as a recording, as well as shorter video and a written summary. And thank you so much to Veloxis for helping us sponsor this session. And we will be back and continue to ask questions. We also have launched on Transplant Life an Ask Me Anything session. So in about 3 weeks, we will have an expert on again, and we will have an interesting topic for you to ask questions to that expert. So thanks and have a good evening.
Thank you.
Thank you.
Bye-bye.
Thank you.